All right, guys, we're going to go ahead and we are going to go get started. So congratulations on making it to exam 3. We've got a little bit of everything in this content, and it's quite cool. Lots of cool, interesting concepts. A lot of it is going to be kind of our kidney care, and we're really going to dive into topics related to excretion and really why the kidneys play such an important role in kind of maintaining our health and well-being on the day-to-day basis. And a couple other things, but they all have similar connections, and hopefully I can help you make the connections between, why someone in end-stage renal disease, why is that somehow similar to polycystic kidney disease, and how do they differ? And that kind of can help you in studying. That way you're not trying to rack your brain for a million different things, kind of recognizing those patterns, because those patterns, whenever we see patterns, that's likely what's going to come up on the exam. Okay, so let's begin. We're going to be talking about good old-fashioned excretion. So first thing we're going to talk about is our BPH. Now, I really love this slide because this is what I want to cover with you all. Really, we're going to be focusing on what are some of these signs and symptoms related to excretion. And as you can imagine, it can be quite uncomfortable for these men and really impedes their day-to-day life. Okay. On the right, you see our TURP procedure, and really we're going to focus a lot on TURP and TURP-related interventions because that is the role of the nurse. While we're not going in there and doing the procedure, you bet that we're going to be taking care of these patients post-procedure. So, why is BPH such a big issue? Essentially, the prostate ends up constricting the urethra and really makes it very, very difficult to have a urine stream and to relieve the bladder. Lots of different risk factors. Usually, they're associated with that increase in testosterone, because that's kind of the hormone related to the prostate. And in addition to just all these difficulties with starting the stream, the fullness after voiding, this overflow incontinence, a big complication is UTIs and kidney damage. Because what happens is we kind of have the urethra, then we go up, we get to the bladder, and above the bladder, we get to the kidneys. So if the bladder isn't able to fully empty, this is when we can start seeing some issues with the kidneys because it's going to cause a backflow. It's going to cause a backflow of urine, and it can go all the way up into the kidneys. Then the kidneys have all this excess pressure, excess fluid, really stressing them out. So again, it's all related, okay? It all goes back to the kidneys, okay? With these patients, you might see some elevated PSA levels, and usually it's going to be diagnosed upon a digital exam. So there's lots of different medications we can do for this procedure, such as more of like our hormonal medications, our tamsulosin, finasteride, things like that. However, if this is a really big issue, these meds take time to work, okay? And this patient might not have a lot of time. It might just be, and even some meds don't work for certain patients. So really, this is a benign issue, okay? So essentially what providers like to do is they like to go in and get it out, okay? So this is the role of the nurse because we're going to be taking care of these patients post a TURP procedure. So essentially with the TURP procedure, what happens is they go in through the urethra and actually pull out the prostate and kind of pull it through, okay? Lots of trauma involved, can be very painful for these patients. And our big concern is bleeds, okay? We had a pretty traumatic operation. So what urology will place is what is called a continuous irrigation catheter. This is going to help us maintain patency within the urethra, essentially. So it's like a two-way catheter. It's going to flush in water to help kind of irrigate, clear out the area, and then allow for us to drain the bladder, okay? Because the last thing we want is any sort of scarring or clots to form, because then we still have a bladder obstruction, okay? Really, a lot of it's going to be that kind of TURP procedure, but also we need to be kind of cautious about the whole bladder issues these patients have, okay? We might implement bladder training for these patients, teaching them, hey, every 2 to 4 hours, even if you don't feel like you need to go, why don't you try? Because we know that these patients just have really big issues with peeing. Additionally, we want to avoid anticholinergic drugs. Well, why do we do that? Those are our dries. They dry you up. That's a major side effect of all anticholinergics. So therefore, we don't want anything that's going to further cause issues with, urinary retention, because they probably already have it. Okay. Up next, we're going to talk about UTIs. So again, excretion issues, okay? Lots of pain, frequency. They might feel like they need to go to the bathroom, and then when they sit down, nothing comes out, nothing happens, okay? You'll also see a lot of flank pain with these patients. And when we talk about a uncomplicated UTI, this is what we mostly think of when we hear UTIs. Not really due to a structural problem, usually due to like dehydration, poor hygiene, things like that. So what we're going to focus on is a lot of our prevention and patient education for this one. Again, why are we concerned? We do not want any infection to travel up north. If it travels up north, then it can infect the bladder. Where does it go above the bladder? It goes to the kidneys. It can cause kidney damage, things like that. As you've heard in clinical, our number one risk factor is actually going to be catheters, or CAUTIs, catheter-associated UTIs. That's why it's really important to kind of see how long your patients have the catheter in, and can we opt for some less invasive options. Okay, what is going to be a major nursing focus for patients with UTIs? Well, we're going to be the ones that need to help them with their clean catch urine sample. So what that's going to look like for us is we're going to be teaching their patient to kind of clean the area beforehand, start peeing, and then probably about midstream, place the cup under, the stream, and then fill up the cup. Okay, it's going to be up to us to help with that education. It's very important for us to get a clean catch urine sample, is because we need to know what might be going on. Okay, and that urine sample, you might see some nitrates, leukocyte esterase, some casts, white blood cells, things like that all in the urine. It also helps us know, well, which antibiotic might we want to use for these patients. A big thing with UTIs is they can cause confusion in the elderly, and that puts them at risk for falls. Really, it's how we treat it is dependent on the cause of its bacteria. We treat with antibiotics. You've learned about your back trim. Make sure you're practicing safe sun with back trim. It causes photosensitivity. We've got different antifungals if it's a fungal infection. It's also very painful, so we can give phenazopyridine, but keep in mind it can turn your urine orange. Okay? So, obviously, we know how to treat the urinary tract infection, but what's better than treating? Prevention. Awesome, primary prevention. So we're going to teach these patients, drink lots of water, wipe front to back, some cranberry juice tablets, caffeine and alcohol, and like citrusy stuff can be quite irritating. And most importantly, just go when you gotta go. Okay. So I do have a little bit of a practice question for you guys. I saw in my survey, some of you didn't like the next gen NCLEX. That's totally understandable. I tried to include less, and at the end, I have more of your traditional style NCLEX practice questions that we'll do at the end. But I think that this one's pretty helpful. So, which of these assessment findings require follow-up by the nurse? This is how NGN is trying to change your select all but apply, if that makes sense. So, of the following findings, what do you think is of concern? And what makes me think, this supports the nursing diagnosis I'm thinking of, or this supports the potential issue I believe is happening? Thank you, Marco. I appreciate it. You can do 1, 2, 3, 4, A, B, C, D. You don't have to type them out. Or if you just see one, just shout it out or put it in the chat, whatever you're comfortable with. So while you guys are figuring out your answers, I'm just going to kind of read this question to you and walk you through my train of thought when I read a question like this. So I see my 80-year-old woman. She came in for acute confusion. Well, what did we just talk about? Usually acute confusion in the elderly might indicate a UTI. Remember, it is acute confusion, meaning she's never had this before. This is an abnormal finding. If at any point you see acute, think abnormal. Okay. I also see that she never has a history of dementia or confusion. So this is pretty new. I also see she's got diabetes. Okay. And when I think diabetes, I think of, she's 80. She might have a little bit of a hard time controlling her diabetes. So maybe her sugar levels are elevated. Why would elevated sugar levels possibly put my patient at risk for a UTI? Well, what if there's a lot of glucose in the urine? That happens sometimes with your diabetics. What do bacteria love? Bacteria absolutely love sugar. So let's see. You guys did really well. Talk about what we think might be some abnormal findings, okay? And a good way to kind of go through this is it normal or is it abnormal? Okay, so always remember your normal lab values for these. So our answers, our elevated temperature, that requires follow-up. 100.8 degrees is not a normal finding, okay? Heart rate, that was normal. Respiratory rate, also normal. But she reported some urgency, some pain, fatigue, some sugar in the urine, and CVA tenderness. That's also kind of where your flanks are. So that is that flank pain. So this might appear as a question on an exam, like, which of the following would be, would a patient experiencing UTI have? And it would be like a select all that apply. So I want to get you guys comfortable with, there's more than one right answer. Okay. I also have another question for you guys. Nurse is caring for a 36-year-old female who reports burning and pain with urination. They don't have a history of kidney disease and report it feels like a UTI. Which urine lab tests support this client's probable diagnosis? So, and it's okay if you don't know all of them, just put what you might think. A through G, what might show up on a urinalysis? And be prepared to be able to read a urinalysis if you have a picture of a urinalysis. They're very similar to like with your antibiotics when you're doing like one of the resistance tests. Appreciate you, Marco and Leah. Thank you. So, is cloudy turbidity a normal finding? No, it's not. Pretty indicative of our UTIs. That is a normal specific gravity. And remember, our urine has a different pH than like our arterial blood gas. So keep in mind. We usually don't ever have protein in our urine, so that is quite abnormal. We've already talked about leukocyte esteries. And then positive casts. That's just our, I believe it's your immature white blood cells. So that's just telling me that there's some infection going on. So good job, guys. And finally, I have a question about our TURP procedure, in case you guys want to kind of tackle this. So, and this could be a good question for you guys. 70-year-old client with BPH and hydronephrosis has undergone a TURP. After returning from the PACU, the nurse assesses the following vital signs: temperature of 99, blood pressure of 116/70, respirations of 16, and a pulse of 70. So, if we were to prevent these post-op complications, what do you think would be really good nursing interventions for us as the nurse? Because all of these are big, big complications following a TURP procedure that we need to be prepared to um, really know how to intervene. So let's start with falling. What do you think we should do to prevent or help with falls with these patients? Definitely having an assist would help. From answer choices 1 through 7, what do you think would be most appropriate? Absolutely. We need to secure the catheter tubes. Remember when we learned how to administer a Foley catheter and there were those clips that you actually stick on the skin? That's to help secure the tubes so that when your patient gets up and walks around, they're not going to trip over their catheter. So, very good job. What do you think we are going to do from of answer choices 1 through 7? And remember, the answers can only be used once to help with this hemorrhage complication. Right. I like your thought process of kind of preparing to administer a um, blood transfusion. I like the thought process, but there's something that we can kind of do first in the nursing process, and that's like our ADPIs, our assessments. What do you think might indicate if I think my patient may be having some sort of hemorrhage? And remember, this is the TURP procedure. So for this one, it's actually going to be number 5. We're going to monitor their urinary output. Why would we be monitoring the urinary output if we're assessing for hemorrhage? Well, remember how this two-way catheter works is that if the patient is hemorrhaging, it will go into that catheter. Um, yes, absolutely. And we will start seeing blood in the urine. That's going to be the first thing we see before we start seeing these changes in vital signs. Okay. What about infection? What will we see with infection? Why would it not be monitor the tubing? Um, there's a better answer choice that involves the tubing. And when it's talking about tubing, it's think along the lines of any kinks in the tubing itself. The tubing wouldn't tell us if my patient's hemorrhaging, but their output would, if that makes sense. Because you would actually see the bloody output. Yep, it's talking about like our physical tube, like kinks in the tubing that might lead to another complication. So, for infection, that's our vital sign 1. Remember, a lot of people tend to forget this, but temperature is a vital sign. Vital signs are not just heart rate, blood pressure, respiratory rate. Blood sugar is also technically a vital sign, okay? Um, temperature, oral temperature, that is a vital sign. So if we suspect infection, we'll start seeing that in the vital signs, okay? What if I notice that there might be, what would be considered the initial post-op period? So in NCLEX world, the initial post-op period is 12 hours from the time they get to your unit, 12 hours in NCLEX world. And in the initial post-op period, your patients are considered unstable. Even if they might be fine, even if they look fine, even if they just had a tiny little procedure, in the initial 12 hours post-op, they are critical. They are unstable. What do we think about obstruction? So to help deal with obstruction, we would, absolutely, Gabriella, we would monitor that drainage tubing. We are looking for kinks in the tubing, okay? Absolutely, check for kinks in the tubing. That's one of the first things that nurses do. We always kind of like to assess for operator errors. So get comfortable with that. Don't think, oh my gosh, there's a blockage. Okay, path of least resistance first. Let's look. Okay, maybe there's just an issue with the tubing. And finally, what would we do for pain? We would administer some antispasmodic drugs. Very good job, guys. Beautiful. And I have a little bit of the answers here. So now we're going to talk about the good old-fashioned kidneys and really kidney dysfunction. So the first thing we're going to talk about is polycystic kidney disease, okay? As you can see, really it does progress, and it is composed of very painful cysts that unfortunately will never go away. Even if we can drain it, even we can stick a needle in it, they're never going to go away. Why are they never going to go away? It is a genetic condition, meaning these patients' genes are literally the genes that help with the kidneys are telling them to grow cysts. Okay, so really what we see most commonly now is the dominant trait. Why do we see that? Well, if you have dominant PKD, you live longer and are therefore able to reproduce. If you have recessive PKD, this usually causes early death early on. So we don't see it too often because those who carry this trait aren't really able to reproduce, if you kind of get where I'm going. So unfortunately, though, after 30, this disease does progress. So our whole goal is to take care of the kidneys and really kind of cushion them, protect them, so that we are not causing further damage to the kidneys in addition to the damage this genetic disease is already doing. So really, we'll start seeing some very stark differences with this. At first, your patient's kidneys will kind of lose a little bit of their ability to kind of filter waste. So all of a sudden, you'll see high output. And then all of a sudden, you're going to start seeing it decrease. In the same way that end-stage renal disease and chronic kidney disease, we decrease. A lot of our lab values are also going to be the same. You'll have this increase in BUN and creatinine, decreased GFR, and decreased creatinine clearance. Essentially, and this is what I want you guys to make the connection with, PKD is a really big risk factor for someone developing end-stage renal disease because their kidneys are not functioning, okay? However, the only difference with PKD, this is a genetic issue, okay? And we want to do whatever we can to help preserve the kidney function so that they don't get to that end-stage renal disease situation. So, this is a very painful disease, so we want to manage their pain appropriately, but we want to avoid NSAIDs. Why do you guys think we want to avoid NSAIDs with these patients? Why would we not want to give them ibuprofen? Absolutely. Our NSAID, there's two things that are very, very, very toxic to the kidneys, okay? It's your antibiotics and your NSAIDs. Very, very harsh on the kidneys. So again, like what I said, we want to cushion and we want to protect the kidneys that we have because in layman's terms, they're not the best right now. Okay, for infections, we can give antibiotics for that, but we want to do what we call renal dosing, and we coordinate with pharmacy to do that. Additionally, what do we know about reduced kidney function? It causes hypertension, and we also know that on the flip-flop, hypertension is a really, really big risk factor for kidney damage. So all in all, we want to help manage the blood pressure, teaching our patient, eat your appropriate foods, do your daily weighs, things like that. So now we're going to talk about chronic kidney disease and end-stage renal disease. If you haven't already checked out the video I did, I in deep detail went into a lot of this stuff. So we're just kind of going to do some more practice questions, but I am going to do a little bit of an overview of some stuff I got on the survey for you all. So really with CKD, just know that through stages 1 through 4, you just start having reduced kidney function. And what in the world do the kidneys do? They filter out waste, they help us pee, they help manage our blood pressure with the whole RAS system and all of that, but most importantly, they help maintain homeostasis, okay? What happens when my kidney function is reduced, all this crud starts to build and build in my body. It can put me in a pretty acidotic state, and that's not good. Also, what happens when I have a massive buildup of calcium or magnesium or sodium or potassium? I can have seizures, cardiac dysrhythmias, stroke, all the above, okay? And when we finally get to end-stage renal disease, my kidneys do not work, and I need what I call the artificial kidney. So it's going to be your dialysis or your transplant, okay? Lots of different complications, so just review those. And really, how do we diagnose? We diagnose with a EGFR. Okay, this helps give us a good average of what the kidney function is. Okay, so what in the world can we do for medical treatment? Obviously, getting the fluid off is very important, so some diuretics will help with that. Also, teach your patient about their phosphate binders. Phosphate and phosphorus is found in so much of the food that we eat. So we can actually give these patients calcium carbonate to eat with their meals to kind of help the body from absorbing all of this phosphate into the bloodstream, and it kind of just goes straight out, if you will, and we poop it out. Okay, one thing to note though, we hold for hypercalcemia because these patients have a hard time excreting everything if their renal function is so low that their calcium levels are so high. Probably not going to want to give this drug. Okay, we can also give them E-alpha to help with anemia and things like that. But we do hold if I have an elevated hemoglobin because I just don't want my blood to get too viscous. As always, we're going to be monitoring for our potassium and calcium levels. We're going to monitor our daily weighs, monitor that albumin because their diet's going to be very restricted, but we still want to make sure they're being nourished. And finally, we're going to avoid lots of medications, not only meds that are toxic to the kidneys, but also most of our antacids and decongestants contain a lot of minerals and vitamins that for me and you are great. But for patients that can't get rid of any of that, it's really detrimental for them. But really, your daily weighs are going to be the most important thing. Also, some signs and symptoms of elevated calcium level. We've got our Chauvet sign and our Trousseau sign, so that lets me know that there's some sort of electrolyte imbalance going on. Okay, and then when we get to that CRF or that end-stage renal failure, this is when we need that artificial kidney. So what in the world does an artificial kidney look like? Sorry, it's going to be our dialysis. So whether it's our peritoneal dialysis or our hemodialysis, we're going to need something to do the job of the kidney. Okay. So I have a PKD practice question for you guys. This is going to be our indicated, contraindicated, or non-essential. So we have a 52-year-old female that was admitted for PKD. Do you think that these actions would be helpful, harmful, or non-related? So let's start with the first one. Do we think we should firmly palpate the abdominal wall and the flank area? What do we think about that? Should we do it? Should we not do it? What do you think we should do? Absolutely, it is contraindicated. It is very, very painful for these patients. If we know she has a history of it, we're not going to go around palpating that and causing pain. Should we consult dietary services for a reduced sodium diet? Do you think that would be helpful for her, harmful for her, or doesn't matter? Absolutely, it's indicated. We want to cushion and we want to protect these kidneys. We know that sodium is not good for the kidneys. So, absolutely, we're going to put them on a sodium restricted diet. We are going to do the renal diet. Very good job. Should we administer NSAIDs for pain control? Helpful, harmful, does not even matter. I like the big strong no. Yes, it is very, very bad to administer NSAIDs and antibiotics. So contraindicated for this patient. We're going to try to use some complementary and alternative methods, if you will. Maybe some heat, whatever we can. Guided imagery. The world is your oyster. Do you think that for this patient, we should encourage fluid intake for them? This one can be a little bit tricky. So this one is actually indicated, okay? Ensuring adequate fluid intake is very important in protecting the kidneys. So when do we reduce when do we reduce fluid intake? That's if they are having, that's like when we're in end-stage renal disease, they have gained a bunch of weight, you can't hear their breath sounds, things like that. So, and that's why also kind of early on in chronic kidney disease, we actually do want them drinking water because if we kind of starve the kidneys of water, it can damage them. So, for this patient, we are going to encourage fluid intake to again help protect the kidneys because she's not in that ESRD yet, if that makes sense. I know it can be a little bit tricky. What about asking about family history of kidney disease? Do you think helpful, harmful, not related to the situation? So this one is indicated. So why is it indicated and non-essential? Well, we know that polycystic kidney disease is a genetic disease. Okay, there is a family history component. That's why for this situation, it's important to ask about family history. Now, if it asked you family history of any eye disorders, that would be non-essential. But we do know that there is this genetic component with PKD, and we do want to ask about that. And last but not least, assess blood glucose levels at the bedside. What do you think about that? I see a lot of indicated. What patients get blood glucose levels? Diabetic patients. We check their blood glucose levels. Heck, maybe this patient's a diabetic, but we don't really know that. So it's actually non-essential for this situation, okay? Did we learn at all about sugar and checking blood sugar on patients with PKD? Not really. Why would we ask about family history if we already know she has it? We know that she has PKD, but it's important to know the family history because you'll start to see that with because sometimes your PKD can be very, very minimal and sometimes it can be very severe. So it's important to ask those questions. We also want to ask family history in terms of, do you have a brother? Do you have a sister? Do you have children that you could have passed this on? So that's why it's important to ask about the whole family history of this kidney issue. And just because, like, again, in NCLEX world, this is a genetic disease, and in NCLEX world, if there's a genetic disease, you always ask for a full family history. You actually go up to like grandparents when we're talking about genetic diseases. No problem. You guys do really well. Again, I have the there's right there. So now we talk about managing kidney failure. So I added these two slides just for some more further clarification. So when we're talking about peritoneal dialysis, this is dialysis within the belly. So blood is not involved with PD. We actually use a sugar dialysate fluid to go in and suck out all of the electrolyte buildups. Okay, why? Because glucose is a puller. It pulls out that urea and that creatinine. Okay, and what's in that urea are potassium, sodium, blah, 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 all of that stuff. So with peritoneal dialysis, okay, it's actually the preferred dialysis. Why is it preferred? These patients can do it every day. So there's need for less restrictions. They can do it every day. And also, they can do it on their own. They can do it from the comfort of their own home. Many of them run their peritoneal dialysis while they're sleeping. Okay, a big thing to note though with peritoneal dialysis is we are introducing a lot of fluid into the abdomen, into the inside of someone's body. So not only can that be very, very painful, but it also is a major risk for infection. Okay, you have an open vessel, if you will, into someone's abdominal cavity. So our big complication is going to be peritonitis for these patients. Okay, so with PD, it's got its ups and it's got its downs. Not super important to know about like how long they're hooked up to. Just know that during inflow, it can be a little bit painful. So we're just going to try to slow down the fluid. Dwelling is different for each patient. Essentially, though, that's just when the dialysate works its magic. And then finally, drain. We're going to help drain. This is why it's also important to do a patient's dry weight, which means getting their weight before you did dialysis. Because after dialysis, ideally, we want them to lose weight. Okay, that's the goal because they're not getting rid of that fluid on their own. But also, we don't want them gaining weight. If they gain weight, that means there's still stuff left. So they might need to maneuver around a little bit, switch positions to help get the rest of it out of their tummies. Hemodialysis, on the other hand, when we think hemo, think hemi, which is blood, okay? Hemodialysis, this is when we have a dialyzer, which essentially looks like a giant washing machine. And what happens is we use what we call an AV. I think it's like arteriovenous. So what are we doing with this AV graft or fistula? Well, we are essentially going to pull from the artery. We're going to pull blood from that. We're going to go ahead and filter it, and then we're going to go put it back through the vein. Okay. So it's important to know that with our AV graft and fistula, we always have to palpate for thrills and auscultate for bruits. This helps determine patency. Why do we assess for two different things? Well, because we have two different things in their arm. Okay, you've hooked up essentially an artery and a vein. Okay, so you've got two different properties. So we're going to make sure that there's patency. However, these take time to heal, so these patients will usually get a temporary catheter placed. okay? It's always important to palpate and just keep in mind when someone has a whatever, whether it be AV fistula or AV graft, you never do venipunctures in that arm. You never grab blood pressure from that arm. Okay, that arm is like their lifeline. That's where they're getting their dialysis. And unfortunately, these patients come in about 3 times a week for 4 hours. And it's quite an issue. Because it's their whole life essentially. And also with hemodialysis, you're not getting it every single day, so you have more severe fluid and food restrictions. Okay, so let's do a practice question. The answer choices are down below. You can only use one for each. Okay, so a nurse is caring for a 54-year-old male with CKD who requires hemodialysis. They have an AV fistula in the left arm. They have a history of diabetes mellitus and fibromyalgia. So you see all of these are potential complications of hemodialysis. So match the potential complication with the appropriate nursing intervention. So what do you think we are going to do for a potential hemorrhage? And why might these patients hemorrhage? It's important to know that too. And we'll talk about it. Okay, let's talk about it. Great job, guys. I see a lot of 2s, and 2 is your correct answer, okay? So NCLEX likes to focus a lot on our prevention stuff, okay? It's also important to know, why might these patients be hemorrhaging? Well, before going into hemodialysis, we give heparin. Why do we give heparin? Well, we're pulling a lot of blood from them. We're putting it through a tube and putting it in a dialyzer or the washing machine, whatever you want to call it. And it can clot in there. So that's why we prep these patients with heparin. So we know that they've had heparin and therefore they are at risk for bleeds. Therefore, we're going to avoid any invasive procedures for 4 to 6 hours after dialysis. What do we think about hypotension? And would hypotension normal, abnormal for this situation? What do we think about that? Yep, hypotension is abnormal. It can sometimes though be expected. I mean, we took a lot of fluid out of these patients. So if my patient after comes back to the unit from hemodialysis and their blood pressure is really low, maybe they took a little bit too much fluid off of them. So absolutely, we're going to prepare to rehydrate these patients. And then they might have to go into a additional round of dialysis, but we treat the acute problem before the chronic problem. So, what about fever? What do we think about fever? Yep. So if my patient has a fever, I'm thinking that they possibly got some sort of infection. So we're going to do some blood cultures if my patient runs a fever. Absolutely. Remember, this is a very invasive procedure. What about DDS? Dialysis disequilibrium syndrome. Absolutely. We're going to assess for those hallmark signs and symptoms of DDS, which is going to be your nausea, vomiting, and your headache. Very good. And finally, pericardial disease. So, pericardial disease kind of goes along the line of our infection one. It's a really big complication. We know most pericardial disease is from a bloodstream infection. So, absolutely, we're going to assess for pericardial rub. Great job, guys. And finally, just a little bit of a word about kidney transplant must-haves. So, in order to kind of go into battle with all of our arrows in a quiver, we want to have ourselves set up for success. So, ideally, we want to have all of our HLAs match. We also want a reduced PRA. This is essentially something that shows, are my antibodies attacking or might attack this. And then we never, ever, ever want a positive cross-match test. We always want a negative cross-match test. If it's positive, it means that there is an immune reaction. And we also have to do this testing, before the kidney transplant, as in when we're trying to figure things out, but also like right before, within 24 hours before we actually do the procedure. We want to make sure nothing changed and everything's okay. All right. A big complication is our rejection. So please, please, please review your hyperacute, acute versus chronic. Hyperacute is an immediate emergency. You got to take it out, okay? Immunosuppressants are not going to help in this hyperacute situation. However, in our acute or chronic situation, we can give some immunosuppressants for life. Corticosteroids also have an immunosuppressant property about them, so you might see a patient be given that too. Okay, so just review that, please. And then finally, restriction. It's not important to know the exact lab values. Just know that we want to opt for low protein, low sodium, low potassium, and low phosphorus foods. Why? It's just because these patients aren't getting rid of these elements and these molecules, and they build and build and build and build. And when protein builds up, it can get toxic. When all of these other fun things build up, it can become toxic. I also included some good foods. Please remember that when we're looking at protein, monitor these patients' albumin. That will indicate if they are malnourished or not. Okay. You have all of these slides. I'm not going to spend too much time on them. Just be prepared to be able to choose proper foods for your patient. Maybe it's breakfast time and your patient needs help looking through the menu. What are you going to want them to eat, and what are you going to tell them no? Please be prepared for that. You might have some photos of a food plate, and it's up to you as the nurse to decide what would be best. Up next, we're going to talk about cancer. I know your cancer precast worksheet was very, very detailed. I'm going to try to help break it up. Really, we're going to focus on breaking it up into two. We have benign versus malignant. Benign is non-harmful in terms of it's not going to spread, it's not going to metastasize, and it is non-cancerous. Usually, it's just going to be uncomfortable, things like that. Malignant, on the other hand, this is our traditional cancer. Just be familiar with the different types of cancers, because it's important to know obviously wording and endings and things like that, but it helps you not get tripped up in questions. If you have a question about a patient with, a basal cell carcinoma, you might get nervous reading that and all those big words, but if at the end of the day you can say carcinoma, skin, it kind of helps you guide your nursing intervention. So if a patient had a carcinoma, you would probably teach them like sunscreen, monitor your moles, things like that. Okay, so I think the four on the right are good to know. What we are going to focus on is our screenings and how to provide patient education. So it's going to be us as a role of the nurse in kind of a public health setting to say, okay, when are we going to start getting these mammograms, pap smears, colonoscopies, etc.? Obviously, if someone has a family history, they're going to require that stuff a bit more frequently because we know they have a history. Okay. I really like the acronym CAUTION because that helps me, a patient comes in, oh, I think I have cancer. Well, let's kind of assess what are some hallmark signs and symptoms. Changes in bowel habits, sores that won't heal, lumps, bleeding, issues with swallowing, things like that. Obvious changes, all the above. Our gold standard is going to be a tumor biopsy. So make sure we get that done. Lots of our complications of cancer are associated with our interventions, which we will talk about. And obviously, we want to prevent things before they happen. So, what are some good prevention we can educate these patients on? Healthy food, healthy diet, healthy activity, good sleep, low stress, all the above. So, really, our nursing considerations for patients is going to be in terms of, prevention. If we can cure it, great. If we can't, let's stop it from getting worse. And if all else fails, we're going to use a palliative care approach. Okay, that's just comfort care. So, really, we're going to be looking at these patients' labs. They are at risk for infection, bleeds, things like that. Big complication is mucositis. They have essentially low everything. They're going to have some low white blood cells, low circulating platelets, low red blood cells. Why? Because usually chemotherapy is going to suppress all of that. And then finally, these patients are on immunosuppressants. So I know we've talked about it lots before, but please don't go out and get a new cat or eat raw and undercooked foods. Now's not the time to go out for sushi. Now's not the time to be taking care of the grandkids, things like that. Now, we've got two forms of treatment for cancer. We've got chemo versus radiation. So, if you're taking notes, this is what I really want you guys to focus on. When we're talking about chemotherapy, how do we keep the patient safe? Chemo is a vesicant. It is very painful. We ourselves need to wear gown, gloves, and mask and like face shield when we're working with chemo because it's very, very toxic. But what does chemo do? It really trashes their immune system. So we're going to be doing our education and our efforts in that realm of things. When we're talking about radiation, our focus now shifts. It shifts to safety of the nurse, okay? Radiation is absolutely toxic, harmful. It is teratogenic. It can cause radiation is very bad. So we as nurses need to know, how do we protect ourselves safe? We do not go in a room when radiation is active. These patients will be isolated from everyone else. We don't touch things in the room. We use forceps. If they have an implant, you use forceps. Everything goes in like a biohazard bag, okay? Reduce your exposure. One nurse should not be caring for every single patient with radiation on that, unit. She should not be having to care for that same patient day after day after day after day because we need to reduce exposure with radiation. Okay, that's why these patients actually will wear a dosimeter. That lets me know how much of a Hulk are you right now, if you will. Are you actively putting out radiation? That's why these patients also need to have their own cutlery, their own plates, things like that. Avoid kids, all the above. So that's where our focus shifts. So pay special attention to the precautions needed for a patient on radiation therapy, and you can find great stuff in ATI. So I have a practice question for you guys. Another one of our indicated, contraindicated, or non-essential. I have a 30-year-old female admitted to the hospital for neutropenia following chemotherapy treatment. The patient has stage 2 breast cancer. So, do you think that these actions are indicated, contraindicated, or non-essential? What do we think about the first one? Should we place the client in a room with another client who has breast cancer? Yep, I like the connection you're making, Marco. It is contraindicated. It is contraindicated because we know that this patient has neutropenia, a low white blood cell count. Therefore, we put them on what is called reverse isolation, where we protect the patient from us normal people who probably have a bunch of germs on us. So that's why this patient would be isolated. They wouldn't be isolated. This patient's not undergoing radiation, so we're not isolating her for that reason. We're isolating her because she has neutropenia. She's at risk for infection, and we need to do reverse isolation. Good job. Should we assess her oral cavity? What do we think about that? Absolutely, it's indicated. We are looking for two things. We're looking for mucositis, and this patient is immunosuppressed. So they're at risk for opportunistic infections, which a lot of that we do see in the mouth. We might see some like um, fungal stuff on the tongue, things like that. So, very good job. Should we monitor their white blood cell count daily? Absolutely, their immunity is compromised, so we want to be checking out their white blood cell levels. We want to make sure they're within normal limits or normal for her, if you will. That will also help us tell if my patient got an infection while she was with us. Should we insert a Foley catheter? Helpful, harmful, not pertinent to the situation. Do we think it would be harmful to put in a catheter to someone with reduced immunity? Do we think that might be potentially harmful? It would be. It's actually contraindicated because this patient is at an increased risk for UTI. Now, if I was a normal, healthy patient in there for, I don't know, a broken arm, it would be non essential to put like a catheter in me. But we know that her history puts her at risk for infection, and we know CODIs are a big, big thing. And that could potentially make this patient go septic pretty fast. All right, should we limit healthcare providers that enter the room? Absolutely, we're trying to reduce exposure. That's the purpose of these reverse isolations. What about assessing this patient's temperature? What do we think about that? Absolutely, we are looking for infection. We know she's at risk for infection, so we want to make sure she does not get one. And finally, last but not least, should we assess the date of the last menstrual period for this patient? So for this situation, it's actually going to be non-essential for her. It's not super important we assess her last menstrual period. Um, I'm not sure if some of the thought processes were going kind of towards radiation, but remember, radiation, we don't want um, pregnancy with radiation. This patient's undergoing chemo, and absolutely, pregnancy would have taken into consideration, but also um, some sort of some types of chemo are actually safe for pregnancy. And there's more research to be done on that. But for now, it's non-essential that we assess her last menstrual period. I don't know if anyone's ever done an admission assessment, but we ask every single patient when their last menstrual period was. So overall, you guys did very, very, very well. Okay. I have one more of these ones for you guys. We've got and it's up to you guys. If you want to do this or we can skip it, just let me know. It's up to you if you want to do it or you think we're good. Just let me know. Okay, we can do it. Absolutely. Marco said he'll go for it, so we'll do it. Nurse is caring for a 64-year-old male client with metastatic cancer to the bone who's now going through 6 cycles of chemo. He has a history of previous lymphomas, diabetes, and asthma. The spouse helps care for him. So, of the following, what would we do to help? And I don't know if you guys have learned about it in pharmacology yet, but I will help you out. Our pegfilgrastim, if I'm pronouncing that right, that drug actually helps us, stimulate more of our immune cells. So that's what that drug does. So what can we do for potential neutropenia of 1 through 7? I kind of gave it away a little bit. But that's a little precursor to some of your cancer meds that you will soon learn about. Absolutely, we're going to administer that to help with stimulating more production of our neutrophils. Yep. All right, what do we think about hypercalcemia? Of the following, what should we do if my patient has really high calcium levels? So it is one, they have really high calcium levels, which can cause some cardiac issues. Remember, calcium channel blockers. Calcium also helps with the heart. So we're going to flush all that. We're going to try to flush them out. Okay. So that's what we do. Aggressive IV hydration. We're trying to flush out that excess calcium. Peripheral neuropathy. What do we do for peripheral neuropathy? Absolutely, fall precautions. They have a hard time feeling their feet, so they might trip. What should we do for mucositis? So for this one, we are going to teach our patient to stop smoking. Essentially, mucositis is just like some irritation, inflammation, sores, lesions in the oral cavity. So that's what we're going to want to do. And finally, we've got our thrombocytopenia. So I'll help you out with thrombocytopenia. These patients are at big risk for bleeds. So what do you think would be best for this? So this we're going to use a small gauge needle for IV access. Good job, guys. And finally, we have some HIV and AIDS stuff to go over. So, I know there's lots of information on these slides, but we're really going to break it down, and I'll tell you what I want y'all to focus on. So really, what do we know about HIV? It's transmitted through like blood, sex, things like that. It is a nationally notifiable disease, but unfortunately, if someone suspects that they've been infected with HIV, we won't really have a definitive diagnosis till I believe 21 days after. So that's why even if they do a test like within that early period, we want them to come back. Okay, what happens with HIV is it attacks our CD4 cells, so it reduces our CD4 count. What in the world do our CD4 cells do? These are our infection fighters. So if I start killing off my infection fighters, my infection that I get is going to run completely rampant. Okay, and this is kind of how we can see these different CD4 levels in these different phases. So in that initial that initial HIV um, process, if you will, that immediate post-infection, these patients might have flu-like symptoms and a decrease in CD4. But as the body kind of begins to fight off the HIV, that CD4 count goes back up, and now they have this chronic HIV infection. Okay. And really, it's important that in this chronic phase, we are continuing to stress the importance of their antiretroviral therapy, stress the importance of like practicing safer sex, things like that. So we want to try to avoid all of these complications, which are associated with the reduced CD4 cell count. So these patients will start having these weird, wacky infections we've never heard of. Who's ever heard of perioral leukopenia, or pneumocystis, MAC, all of those, crazy diseases, because we don't see that in the healthy population because our immune systems fight it off. But with HIV and similar to cancer patients, they are at risk for infection. Okay. So what can we do for some treatment? Well, we have PEP and PrEP. PrEP is our pre-exposure prophylaxis, and this is for people who maybe they found like the love of their life who just happen to have HIV and they want to protect themselves. Well, they can use PrEP, but PrEP only works if you're HIV negative. We also have what's called PEP, post-exposure prophylaxis, which is what you would do if you had a accidental needle stick with like a patient who had HIV. Okay. And then finally, we've got our quote unquote treatment. The goal of treatment is to reduce the viral load and increase our CD4 levels, but there is currently no cure. Okay. You'll learn about them in Pharm, but it's going to be our CART, our NRTIs, NNRTIs, things like that. Okay. AIDS, on the other hand, this is when HIV progresses, and usually we don't see this too much because of the treatment nowadays kind of helps prevent our patients with HIV from progressing to AIDS. But unfortunately, this usually happens within about 5 to 10 years with no treatment. Okay, and this is what happens when my patient's CD4 count gets so low, lower than 200, that their body physically cannot fight infection anymore. So these patients won't die of AIDS, but they will die of pneumonia, of the flu, of strep, things like that. Okay, so our focus is really going to be on keeping them safe. Your AIDS patients, same thing with chemo, reverse isolation. Okay. Finally, a little bit of a blurb on needle sticks and what to do. You're going to need to bleed the wound, rinse it, and start your 3-day CART therapy within 72 hours. Keep in mind, your HIV patients are still under standard precautions. There's no need for like walking into their room and using gown and glove and mask. They are under standard precautions. Why are they under standard precautions? Whether my individual has HIV or they have no known bloodborne issues, I still always wear gloves when coming in contact with bodily fluids. That's why they're still under standard precautions. Alrighty. I really, really like this question, so I hope you guys want to do it with me, because this can be applicable for chemotherapy and reduced immunity, which is bound to show up. So, we have a 52-year-old male client who's HIV positive and is now in HIV-3 status with high risk for developing opportunistic infections. They're not AIDS yet, but they're kind of getting there. We're now going to educate them on preventing infection. So, of the following, what should we teach the patient to do? Should we tell them not to change cat litter boxes. The slides are not updating in the presentation. I'm sorry about that. Are you able to see this slide now? Yes. Okay. Perfect. So, do we think that patients at risk for infection should be changing kitty litter boxes? Absolutely not. There's actually a lot of opportunistic infections that thrive in cat feces. So absolutely not. Should we tell them to avoid cold or cool liquids? Nope. The cool liquids doesn't have anything to do with infection prevention. What about cooking their poultry and eggs before eating? Absolutely, we do not want any raw or undercooked foods. What about having them bathing daily using an antimicrobial soap? Absolutely, very good. What about wearing gloves when digging in the garden? Absolutely, 100% we do. What about wearing sufficient clothing in the winter? Will that help at all with preventing infection? It's actually no, it's like a myth that when you go out with wet hair, you're going to get sick. That doesn't help prevent infection. What about washing dishes in hot sudsy water or the dishwasher? Absolutely, we got to keep them clean. The good old NCLEX toothbrush question. Cleaning your toothbrush daily in the dishwasher or rinsing it with bleach? Do we think we should do that or not do that? I'll help you out. We actually want to do that. I could not tell you why, but NCLEX has a thing for toothbrushes, and it shows up in public health and it shows up in MedSurg too. It shows up everywhere that if your patient's at risk for infection, they need to be thoroughly cleansing their toothbrushes, even in the dishwasher. Yep. Um, what about wearing a medical alert bracelet that they're immunosuppressed? This one's a little bit tricky. Um, because that's really not what the medical alert bracelets are for, and they don't need that. And then finally, what about getting their yearly influenza vaccine and the recommended pneumonia vaccine? So, this one is actually no, because some of the influenza vaccines contain live viruses. Um, so these patients, remember, immunosuppressed patients can't get live vaccines. All right, now I have some of your regular practice questions, if you will, that are more likely to see on your upcoming exams. Very true. The toothbrush question always trips everyone up. So, which of the following are warning signs of cancer? Select all that apply. Remembering your caution helps a lot too. It's not updating again. Let me try. What about now? Perfect. So, A, B, C, D, and E, what do we think could be warning signs of cancer? So, if we use our acronym CAUTION, so it is going to be our A, our our A, our B, and our D. Remember, changes in bowel or bladder, that applies to A. A scab, that's a wound that won't heal. Our axillary swelling, that's kind of like the underarm breast area. So we know like an abnormal lump. It's not headache because while it can be common, it's not a warning sign of cancer, if you will. Plenty of things cause headaches. Stick to your caution. Client with leukemia has neutropenia. Of the following functions, which should be frequently assessed for a client with neutropenia? So our patient has leukemia and they have neutropenia. What are we going to assess frequently? Should we be assessing heart sounds, bowel sounds, breath sounds, or blood pressure? So this is the battle of the most correct. The answer is actually going to be C. We are going to be assessing breath sounds. Why? These patients are at really big risk for pneumonia, especially while in the hospital. So we assess those breath sounds to see if they might be developing pneumonia. While blood pressure is a contributing factor in sepsis, we'll learn more about sepsis and complex health too, but a drop in blood pressure won't really indicate sepsis, if you will. Septic shock is composed of a couple different vital signs, but not strictly just blood pressure. Um, so it is actually breath sounds because of pneumonia. I have a TERP question. After undergoing a TERP to treat benign prostatic hyperplasia, a male client returns to the room with continuous bladder irrigation. On the first day after surgery, the client reports bladder pain. What should Nurse Anthony do first? So if we follow the nursing uh, if we follow like our nursing process, we're going to assess first. We're going to assess the irrigation catheter for patency and drainage. Maybe my client has pain because there's a kink in the tubing and it's draining properly. Maybe there's blood in the drainage, and that's what might be contributing to the pain. So we're always going to assess first. We also know that they're on this continuous bladder irrigation, so they have this foreign body that's being, introduced into the body. So absolutely assess that catheter. A patient with stage 5 CKD is experiencing extreme pruritus and has several areas of crystallized white deposits on the skin. As the nurse, you know this is due to excessive amounts of what substance found in the blood? Awesome job, guys. So it's B. This is our uremic frost. Okay, this is really like only shows up in that severe kidney disease. And this is because this urea is just building and building and building, and it can actually be very, very itchy and very uncomfortable. Very good. All right. You are providing education to a patient with CKD about calcium acetate. Which statement by the patients demonstrates they understood your teaching about this medication? Select all that apply. So remember, calcium acetate is a phosphate binder. Please, please, please go ahead and review your phosphate binders. The whole purpose of these is to take them with food so that it binds to the phosphorus and we don't have phosphorus buildup in the blood. So it is going to be our B and our D. And while this helps, we still want to reduce overall phosphorus consumption. Love it. A client receiving hemodialysis treatment arrives at the hospital with a blood pressure of 200 over 100, a heart rate of 110, and a respiratory rate of 36. Oxygen saturation on room air is 88. He complains of shortness of breath and 2+ pedal edema is noted. His last hemodialysis treatment was yesterday. Which of the following interventions should be done first? Absolutely, guys. It is D. We look at these vitals, we see an O2 sat of less than 90. Therefore, we use airway, breathing, circulation. We're going to give them oxygen. Absolutely, we're going to restrict fluids, but right now it's not going to help much. Yes, we're going to prep them for hemodialysis, but there's something we need to do first. Boo-boo-boo. A 30-year-old patient is in the acute, also known as the initial stage of HIV. What findings below correlate with this stage of HIV? Select all that apply. I see you, Marco. You're all good. I think we have like 2 more questions. So 2 or 3 more questions. So you're good. So remember, in this acute initial stage, this is when my patient has just recently been infected with HIV. Therefore, they haven't progressed to those opportunistic infections quite just yet, but in that initial infectious stage, they will have a very high viral load with a low CD4 count, but it's going to be quite low. So the answers for this is going to be B and C and D. So very good job. All right. Patient arrives to the clinic and requests an HIV test. The patient had unprotected sex 2 days ago with someone who may have HIV. As the nurse, you know there's a window period for detecting an infection of HIV. What statement should you provide? So this one is A, B, C, and D. Remember in that initial post-day infection, you're not going to be able to quite see that. And these window periods different. So in a nutshell, when testing someone for HIV, we really don't have current requires the nurse to re-educate the patient about this topic. It is going to be B. We don't want them having raw organic milk because that is not filtered. Okay, it's not filtered, not pasteurized, and really at the end of the day, not safe. All right, guys, I have one more practice question for you all. What sign and symptom in your patient with HIV indicates the disease is worsening and the immune system is severely compromised? The answer choices are open oozing lesions, white hairy spots, cheesy film, and vision changes. It is going to be these white hair-like spots on the tongue. That is the opportunistic infection, hairy oral leukopenia. This is not a select, all that apply. The open oozing lesions could usually be that mucositis. The cheesy white film, that is more of like a fungal stuff. It's not quite an opportunistic infection though. And vision changes is unrelated. But I could totally see you guys picking C and I wouldn't be opposed to it. But really, B is that hairy oral leukopenia.